Hello, everyone. This is Cheryl Parker. I am the president of the American Nursing Informatics Association, and it is my honor today to be joined by Gretchen Brown, the Associate Chief Nursing Informatics Officer at Stanford Health. And along with her is Patrice Duhan. She is the Director of Epic Optimization and Reporting for Stanford. Thank you, ladies, for taking some time out of your busy day. I know we're all insane, but I really do appreciate you coming on and sharing information. So let's just jump right into it. Could you tell me a little bit more about your organization?
Yeah, thank you, Cheryl. Stanford is a 600-bed tertiary care facility. We have our own Life Flight helicopter and program. We love our certifications here. We have VAD, we have cardiovascular, we're comprehensive stroke, we have a rigorous busy ED. We have some unique qualities where we're connected with a children's hospital, but have a different instance of Epic. That's been a little bit of a twist. And we also have a community hospital, which is on the same instance of Epic, but again has unique challenges since we deliver very different care. We were uniquely situated last fall where our volumes just skyrocketed. So we were well over our licensed beds with 40, 50 people boarding in the ED. And so we had already done a lot of work working with our California Department of Public Health to create alternative bed locations and making sure that those offered all the things that we as clinicians need and the patients need to deliver the same level of care. So I think we were lucky that we had a lot of this in our back pocket to really leverage during the COVID potential surge. The beds that we had created in the past look and feel just like a regular Epic bed. They're mapped to all the 22 downstream systems, all the way down to our nutrition system. The Philips monitors are mapped. We use transport monitors, and they read to the central stations just like any other monitor. So we were positioned to leverage a lot of those different past work from our high census. We did, and we appreciate sessions like this because on the West Coast, watching internationally what was happening with the COVID surge, and certainly our friends in New York, we very much got the message from watching informational sessions, checking message boards on some of the sites, not necessarily listening to the news, but really getting informed by the clinicians who were experiencing that surge. We very much knew that time was of the essence. And if we were going to plan, we needed to plan quickly. So it really leveraged, I think anytime you're in an academic medical center, you have a lot of brilliant people. We are no different. It's how you channel, coordinate, and organize that work is important. I think we really did a nice job at Stanford as an enterprise to quickly stand up some leadership structures to coordinate that approval, the policies, everything from PPE, conservation, to what does it look like to have a new test that one of our PhD people had created in the medical school, and how does that affect and influence your workflows when you're going from a testing period of 2 days to a testing period of a couple hours, and how do you pivot, how do you communicate, and how do you disseminate that information? I think one of the things I'm particularly proud of, and our friends and partners in the education center really stepped in and helped us not only with the information that leadership was trying to disseminate, but as the clinicians, as the nurses, as the informaticists who were developing new workflows. Educators have a much better way of crafting that message so it's digestible And so they really stepped in to help us recreate our intranet site that was purposefully multidisciplinary, covered physicians, respiratory therapists, everybody who touched the COVID process, which, as you know, is everybody. And it has to be in a format that people can digest quickly, leverage quickly, access. They spent a lot of time with links that were mobile friendly. We are the lover of the QR code now at Stanford, and really understood that as people were trying to digest the information, not that they were hearing just in their personal lives, but how every day they came in, CDC guidelines were changing. I think that was a challenge. And so they really appreciated those quick QR codes that popped up a 30-second to 1-minute video or information that they could just grab and go, that updated information. It was hard. It was hard, you know, watching people in New York, that's what they talked about. How do you keep ahead of the changing, you know, landscape of COVID? And I think we really did a nice job leveraging some of our informatics tools, but really coming together as a whole enterprise and accessing all the talent that you have to make the work that you do better. So thank you for the opportunity to talk with you today.
Yeah, I just love the sharing. Could you talk more about how, as COVID ramped up, I mean, I really appreciated that you said we weren't necessarily listening to the news, we were listening to other clinicians. What were they seeing? What kind of other changes did you make as far as technology, telehealth, communication devices, and communication devices, not just between clinicians, but anyway, because I've heard some really unique stuff.
Yeah, I think as we were watching the surge happen in New York, we took to heart, and certainly the CDC helped us ramp down our volumes. You know, surgeons don't typically embrace the limiting factor, but we did here at Stanford. And that really allowed us to bring down the census and be ready for a potential surge. I think it was also an interesting phenomenon for us that with the shelter in place and with the fear that is in the community, people's confidence to come into the ED, people were scared. And the volumes in the ED, we're a little worried that we have a large oncology, transplant, cardiovascular population, that they were staying away. And so the video visits skyrocketed. We went from 1%, I'm not really sure if this is the technology I want to use group, to video visits with patients of 70% of their volume, because they wanted to reach out to these patients and really keep a tab on them, checking on them at home. You know, when you've had a bone marrow transplant, the worst place is the hospital and the best place is the hospital, but you need to know when that is. And I think the physicians really leverage that technology to stay in touch with that group outside the hospital. And I think that was very important from our patients. Our patients talk about that connection that they felt to their clinicians, because they were very isolated. I think within the hospital, we quickly pivoted. Many people were leveraging the Zoom teleconferencing solution. I think we did as well. We got a lot of feedback from our physicians around not only that they had the iPad to do the teleconferencing Zoom, but wanted it pointed at the patient so they could really look at the patient. You know, my mom is not the greatest user of the iPad, and every time I FaceTime with her, I'm looking at her neck. Well, that's not helpful if you're a physician and you want to virtually pop into the room and check on them, just like when they round, right? The physicians kind of peek their head in, how are you doing? Or just watch somebody sleep, right? So they were trying to do this, like, how do I look into a room? How do I see somebody, the effort that they talk? And so we put our iPads specifically on carts pointed at the patients. And we also valued, you know, there's one thing to have a physician who wants to pop in, but there's not always an appropriate time to pop into a room. And as a nurse, you know that. And so we set up some guardrails so physicians just couldn't sit at home and pop into any patient room. They needed to kind of check in with the main station and coordinate that visit, because patients didn't approve if they were perhaps on a commode and you as a physician popped in to say hello. So I think we got a lot of feedback. Interestingly enough, though, we got probably the most significant feedback from the non-COVID patients. The isolation that the patients that were in the hospital felt as we all clamped down on our visiting guidelines. Ours are very stringent. Only certain instances can people have visitors. And that was really hard for a bone marrow transplant patient who was in the hospital for 30, 60 days, or an oncology patient. And so we got a lot of requests from those areas to have extended teleconferencing with families. And so we pivoted to a different workflow where our guest services department deploys these iPads so people can keep them in the room, and they can teleconference with a family over an hour or so. I mean, that was very compelling when, you know, they're just stuck here, and we don't want them to feel like they need to leave, but it was affecting patients. And also, I think that population, while they weren't COVID, we didn't want the group at an academic medical center rounding on them 15 strong, like we all know that they love to do. So instead, they would send maybe one person in, and the rest of the team would teleconference in. So they were at the main station, and maybe the attending went in. So there was a lot of workflows that were developed from very quick feedback from our clinicians around how do you connect. I think it was very interesting one day when I was rounding, and a nurse was teleconferencing into all her patients' room at the beginning of the shift. And I asked her, like, what are you doing? She's like, well, I think it's very important that my patients see my face and talk about how this hospitalization may be very different for them before I walk in all donned in PPE, because it's frightening. And so she did that at the beginning of every shift. And I really thought that was just an excellent way to connect with your patients that, you know, that really was very compelling. And it was funny because I kind of leaned over into the screen with the patient, and he's like, well, who are you? And I introduced myself, and he said, I think this is great. Like, I don't want to stare at my door all day long, but that's what I feel like I'm doing because he's a COVID patient behind a door. So it really sort of brought that humanity to light, and was just a really great kind of exemplified how our clinicians are super smart, and you have to spend the time with them rounding to get these experiences.
And we will definitely figure out a way around any workflow.
Oh, yes, they have.
If it's not working for us, we'll figure it out. So
Yeah.
Patrice, I'm going to flip over and ask you, what kind of changes did you guys make in Epic? You know, did you come up with new flow sheets? Did you modify existing flow sheets? I mean, we were all concerned even before this started about the burden of documentation, and this just blew it up.
Right.
Yeah.
Yes. So we actually had a little bit more time because we didn't really see a surge here at Stanford. So it gave us the opportunity to really take a look at some ways that we could start thinking about what documentation reduction might look like during a disaster. So we put together, we started a documentation task force, and we invited some key stakeholders and experts to the table, like some of our practice experts from the CNS team, from the ICU region, and the acuity adaptable unit regions, which is also like MedSurg and Tele in other areas. We also invited some of our EPIC analyst colleagues to help guide us. And then we also, some folks from the regulatory department who were at the table who could really bring the CMS guidelines and the Joint Commission guidelines to the table to sort of help start a conversation on what would documentation reduction look like. So we also invited a couple of our nursing quality coordinators who are the experts in problem solving and EPIC enhancement, and who also are very connected to our frontline staff and to some of our staff and some of our managers. And we consulted, of course, our risk management and for their guidance and our awareness. And then the first thing that we did was to socialize what we were doing. So we wanted to let the organization know that we were looking at documentation reduction during a disaster, and we wanted to generate some ideas. What did some folks have to say about that? And so we did get quite a bit of feedback from our frontline staff and our managers and people who had some concerns. And one of the main concerns was that they didn't want to see some new technology be, rolled out during a disaster. And so we knew that we wanted to leverage some of our current workflows and that we're using currently, so that we wouldn't do that to them. And so we wanted to just enhance some of the current technology that we had, if at all possible. We also knew that we wanted to just look at some industry best practices, and we basically look at what EPIC had to offer. This was not the time to recreate the wheel like we do often, especially at university hospitals, right, or university organizations. So that was sort of like some of our guiding principles early on. So we looked at some best practices and some recommendations, like at Vanderbilt. We studied them quite a bit, and some of the best practices that NYU is doing as well. So we went to sort of the front lines where all the surges were happening to sort of study what they were doing. And of course, we did leverage our colleagues at EPIC, and they had a just wealth of information and some ready available tools that we could just plug and play, so to speak, so we could get started pretty quickly with that. So we're not done with, our final design. And so next we're going to mock up what we think staff might like, and we're going to bring it back to them, the frontline staff, and let them help guide us to our final decision and production. So a little bit more to do there. And then we want to make sure that we align with our physician informatics team as well, and our ambulatory teams to, just to make sure we're all on the same page. And I know that there's work to be done there as well regarding documentation reduction. So that's what we're working on now. The other thing that we did that was really neat, Cheryl, that I'd like to talk about is some of the dashboards that we created and some of the flags and banners. Gosh, this really, really helped to guide our decision making. So early on, we created a COVID capacity management dashboard. And this was a different dashboard than what EPIC had to offer, like the plug and play executive dashboards that were out there. This was one that was homegrown here. And so this gave us real-time visibility into the types of patients that were coming into our organization. And it also helped with decision-making, and it also helped us to project, if we would have a surge and where those patients would go. It also helped us to guide us, what areas could we surge into? How many ICU beds do we need? How many ventilators do we have on hand? Or in that case, what would the potential staffing needs be? how many negative pressure rooms are we using currently, and where could we move if we needed more negative pressure rooms. So that tool really helped guide us, and we still use it today. It's very valuable. So the other thing that we did early on is created flags and banners. So we heard from our staff and from our physicians, we have to wait for the test result. Then we have to go back into the system and go to a couple of areas to see if the patient is positive or not. Can we do something about that? And so we quickly created some flags and banners with the help of our infection prevention department. So at a glance, the staff could identify if a patient tested positive or who was being tested. It was color-coded, it was very visible, it was always there every time you opened up the chart, so you didn't really have to search for any test results or anything like that. So it was very well liked. This also helped with preserving PPE, and it also helped, our staff feel a little bit more comfortable too in taking care of the patients early on, because they had such visibility and they didn't have to wait for the information. So yeah, those are some of the quick and dirty things that we did right away. Some of these things that I just mentioned would probably take, a couple of months to really get up and running. But amazingly, everybody just worked together. And within a couple of days, we had all this up and running, and, people were able to utilize the technology to their benefit. So that really helped.
That seems to be a common theme between the interviews I've done. Is how we really did expedite way outside of our normal parameters. What normally took weeks, people were accomplishing in days, which kind of says, well, guys, maybe we need to think about our processes overall. Because I think one of the things that's been interesting about this disaster is we've always, being an old ED nurse, we've always thought of disaster as this really short, self-limiting event. It's quick, it's big, but it's over fairly quickly. The explosion, the bus crash, the train wreck, it's not months and months of still potential problems that you don't know which way things are going to go. So I think we've really had to change our thinking about what a disaster really means anymore in today's world, because we're a global society. So could you share with me some of the lessons you learned and what you might do differently, and what things you think might stay based on what we're doing?
Yeah, I think we sure made a lot of mistakes with pivoting quickly, right? So that's where I think it was really important for us to, while you can get things approved quickly, you need to put up and maintain and support the rigorous structure for approvals. Because boy, we had people flying in multiple different directions. So I think that's always a risk. It's really great to stand something up, but nothing you can do in the EHR doesn't have multiple domino effects. So I think just thinking through that, we do a good job now, maybe not on the initial launch of some of this stuff, by having all the right people on a quick, task force meeting. Certainly everybody meeting virtually, it sure speeds up your ability to connect, I have to say. Right, because you can just all jump on a call really quickly and talk it through. So I think we have all embraced the Zoom and WebEx meeting, and everybody should be proficient. But I don't think we were before. So I think this way of communicating and meeting, this will stay. It was an interesting kind of phenomena within nursing. Nobody had cameras on their computers, nobody turned on their camera, and we're connectors. We want to see people. And so that was one of the the early kind of complaints, like why isn't nursing have their cameras on? We just never thought about it, right? And having a meaningful meeting with people around the table, you got their attention. Well, when you do that on Zoom and WebEx, you should have their attention too. And so having a camera on so you see people aren't multitasking, I think that will stay, right? I think some of the technology, like the teleconferencing, we did a lot of unique things with that. The ED used it pretty significantly to do assessments and through their drive-through triage. I'm not necessarily sure that's the final form factor for that workflow. It may be, but I think what we really should do is keep getting feedback about it to enhance it, work with those partners to see what they can do with those applications. So I think being nimble and thinking it through, you know, we're leveraging a remote sitting application as an eICU, which, you know, we had it in our environment. Again, will that be the final form factor? I don't know, you know, but I think continuing to listen to the clinicians to really keep honing into what exactly are the requirements, you know, and not just having them react to the current technology that you give them. I think the clinicians, this has been kind of a unique experience for them, that they've really had to pivot and experience a lot of this new stuff in their environment and make sure that they're clear about what are the requirements, or why keep it, why use it, was it worth the investment? So I think that will stay with us. You know, I have to say, when you round pre-COVID means a little bit different than you rounding post-COVID. We're a little bit more careful about how we round, but that makes it particularly challenging when you're trying to get feedback or having, you know, focus groups or stuff about some of this technology. So I think we're still thinking through how we do that as robustly as we should. I have heard and appreciate a lot of the academic medical centers, and I don't think we're unique. It has significantly brought together our physicians and the nursing staff around responding to COVID. You know, when we put a safety officer on a unit, they're not only responsible for the nursing staff, they're responsible for the physicians and how they don and doff and every other discipline that goes in the room. So I think that will stay with us, this new connectedness, responding to this kind of new disaster. And finally, I think when you respond to a plane crash, as opposed to this long duration of a disaster, I think cycling out and making sure your leaders get rest and you don't only have one person with all the knowledge has been kind of an aha moment for us, because people are tired, right? They don't get away from kind of this disaster in their personal life, and when they come to work, it can be high tension. So I think that's something that will stay with us as well.
Patrice, anything you want to add there that you can think of?
Oh, gosh, she really said that very well. I mean, we've all had to step into unusual roles during, you know, battling this COVID epidemic, and you know, it's just made us more humble. You know, you'll see people stepping up to the plate, wanting to do more. You'll see staff wanting to do more. You know, during one story, quickly, I know we're probably running out of time here, but we also had to open up a labor pool because we quickly had a surge of folks who did not have jobs to go to. Basically, the job was still there, but because our patient population had decreased so much early on, we had a surplus of staff. And so we quickly, tried to find other things for them to do. We deployed them different checkpoints because we all of a sudden had to do symptom checks and all of these different things, and closed down some of our entrances. And then we had things like lab runners and PPE runners, so all new job roles. But one of the really interesting things that stuck with me is during the no visiting, and we still have no visiting now, one of the staff members created a team of nurses that could go and visit with patients. So you could sort of call for a visitor, if you needed one. So I thought that was very heartwarming, and very clever. And very clever. And so, during that time, the nursing staff, or it could be anyone, that was in the labor pool at the moment looking for work, to just be deployed to read a story to one of the patients or whatever they needed at the time. So yeah, I really appreciated that story and working in the labor pool too.
And I think, Cheryl, just Patrice is being probably modest. We were two leaders that, when you're in nursing and something comes up, like, welcome to your new job, right? So Patrice stepped in with another leader to stand up the labor pool, right? It's not a traditional department. We sort of had a skeleton plan from some of our past disaster, but the details really hadn't been flushed out. So Patrice stepped in as a director there with another nursing leader. And so when you pull great minds together, and one happened to have an informatics, background, like, you create great things. And, I stepped in to be not only the informatics officer, but the associate chief nurse for inpatient. And so that's why it was easy for me to roll out some of the IT platforms, because that's my wheelhouse, and you have a great opportunity to bring the two worlds together. I think that's what happens in these situations, is you leverage people's expertise in different ways that you never did.
Yeah, I think people find things within themselves they didn't always know were there.
Sure.
And that story, Patrice, really kind of leads me to my next question. And it's certainly becoming a concern across the country, and that's the mental health services.
Yeah.
For everybody from the janitor to the chief of medicine. What are y'all doing about mental health services for our staff and our families and our patients and et cetera?
Yeah, so I think the teleconferencing and just the accessibility on a broad scale. And then I know psychiatry is really leveraging the telemedicine within their clinic in a very different way. And they talk about just the access, the more regular access to the patients that they're having via video than planned visits. And so I think that will change their world and how they do touch points with their patients. I think that we did have a lot of rounding going on. We did have nurses checking on other nurses who had tested positive. That we had no nurses that converted from exposure to patients, but certainly nurses were exposed in their personal life. And so really tried to find a way to support each other there. And I think one of the when you get tested, one of the interesting things is you want the result right away, right? We're all like that. And we leveraged our My Health platform. And so if you are a current patient, you have My Health like I do, but you could download it and become a My Health customer. And so when you went to occupational health, you got the immediate results through My Health as an employee. And so again, it's leveraging those existing platforms in a better way. And so now employees are getting results very quick about their swabbing, which is a fantastic experience if you haven't tried it. Right. And about your antibody.
Oh yeah, I always love having things rammed all the way up my nose.
Yeah. I'm glad that she told me how she was going to do that, because I would have thought she was doing it wrong. But anyway, and then the antibody test to just get that results real time with kind of some background information for you. Even as a clinician, it's good to have the information. And so that was really something that we evolved into. It was a little clunky at the beginning, and I think that was a lot of feedback from the staff is, I can't get my result. I'm anxious. I don't know what to do at home. I have young children. I have an elderly parent. What does this mean? So I think, people get anxious through that waiting period. And I think getting the result quickly was super key. And leveraging that existing technology certainly helped us.
So one last question before we wrap up. What are you guys doing to prepare? They're talking about a potential second wave along with regular influenza. What kind of things are y'all thinking about for that?
Well, I think a lot of the work that Patrice is doing and will continue to do, I think is important. People are engaged, and I think we'll get a lot accomplished over the next couple months, in spite of not getting the surge, thank goodness. But we do have units that we readied. We had some decommissioned units that we stood back up. So they're shuttered but ready to be opened within 4 hours. We have those surge beds ready for population if we need it. So I think what's also very important is the labor pool that Patrice was part of to document all that very robustly, because we will be pulling that plan back off the shelf, right? And all the work, we're not always great about really documenting all that in a way that the next person who comes along can really take it back off the shelf. And Patrice, I don't know if you want to talk about some of that discussion about the labor pool.
Oh, the labor pool and some of the staffing models that we made?
Well, just the documentation of all your planning.
Oh my goodness, yes. So, so a lot of thought and process went into that, and of course, involving all the different departments and working with HR, and working with our facilities management and all of those things. So, and trying to really establish who are our essential workers, who are our non-essential workers, trying to figure out, who these folks were, and if we needed to deploy our stand-up and ulterior practice model, who are these folks that are going to help us do that? So, continuing that work, because it's not, fully developed, but to make sure that we get that documented and to put it in a standing operating procedure, so that we can just pull it out and we don't have to start over.
Yeah, when it's not a regular department, somebody doesn't take forward that information. Like,
right,
we all return to our regular roles. There's nobody really responsible for that. And I just hope I never have to experience this again. And I'm not sure what Patrice thinks about standing up a labor pool again, because it certainly made long weeks and long days. But, you should, just like these sessions, Cheryl, you should hand forward the information, share it, and make sure it's in a format that other people can really utilize. We know at Stanford, we are unique and have a lot of resources, and we acknowledge that we should be the sharers out to those communities that don't have the resources that we have.
I was going to say, well, certainly if there's documentation or standard operating procedures or something that you'd like ANIA to help you share, please just let us know, because we'll be happy to put it out there for the informatics community at large. So anything else that we forgot to talk about, or anything else that you really have a burning desire to share?
We've done so many unique things, in the ED drive-through triage. They're taking pictures of driver's licenses and then sending them over our secure messaging system to the registrar who's sitting inside the ED to decrease exposure. Like, some smart person thought that through and leveraged our existing technology. So that was really kind of interesting. And all the ways we've used those iPads, I don't even think I can count the many ways we've, you know, leveraged that teleconferencing. We are all in on that. And, you know, I think we're at a point now where, you know, we really need to decide what is the final form factor, what really works for the patient and the clinicians going forward. And I think that it'd be interesting to see what, you know, all the different centers do with that information.
Yep. And I think there's going to be a whole lot of research comes out of this in a variety of areas, especially, you know, hopefully my PhD side kind of pops up and says, oh, we could research this in the informatics world. We could research that. So
I know.
I hope a lot of it gets done. Well, ladies, I just want to say thank you so much to both of you, Gretchen and Patrice, for spending some time with us today. I know this has all been a crazy, I mean, I can't believe it's really only been 3 weeks since we started these interview processes. And I'm not even sure it's actually 3 weeks yet. I'd have to go count. But it's really been great to be able to talk to everyone and share information and see this kind of information disseminated. So thank you so much. Like I said, if you need any help disseminating documents, just let us know. And may you all have a very safe and wonderful summer. It may be a different summer, but it'll still be summer.
Yeah, it will be. And same to you, Cheryl. Stay safe.
Thanks so much.
Thank you so much for the opportunity. We really appreciate the time to share. Yes.
Thank you.